Welcome to the deep dive. Okay, so today we're digging into the sources you shared on cardiac murmurs. It's quite a dense topic, actually.
It really is.
But it turns out it's this fantastic shortcut into, well, systemic diagnosis. A murmur, it's just a sound, right?
Fundamentally, yes.
But our mission here is to get past just the sound and pull out the clearest, most useful nuggets of knowledge, things that really help you distinguish, an innocent little whistle from something truly dangerous.
That really is the core goal, isn't it? We're not just memorizing audio clips. We're learning a kind of specialized language the heart speaks.
A language? I like that.
Yeah, because a murmur means turbulent blood flow, sure.
Yeah.
But the type of turbulence, the timing,
Yeah.
that tells you exactly where the problem is. Is it a structural issue, or is the heart just coping with some, weird systemic state?
Okay, good distinction. So let's start with maybe the easier ones. The false alarms, you could call them. Sounds that happen, but the heart structure itself is fine.
Exactly. Laying the groundwork. These are situations where the heart is functionally completely normal.
Right, so these are the physiologic or benign murmurs. The sources kept hammering this point. Structurally, nothing's wrong with the valve. The door is fine.
Mm-hmm. It's more about what's going through the door. It's usually about the sheer volume or the speed of the blood.
Okay.
Think of it like basic plumbing almost. You get turbulence in a pipe if there's a hyperdynamic state. So maybe too much blood volume overall.
Like in pregnancy. The notes mentioned that one.
Exactly like pregnancy.
Wow.
Big increase in blood volume, higher cardiac output needed for the fetus.
Yeah.
That causes flow turbulence across perfectly normal valves.
Okay. What else causes it?
Or the blood itself could be too thin, low viscosity. That's the classic anemia picture.
Ah, right. The pale patient, maybe a bit tired.
Yeah. You hear this soft systolic murmur, maybe grade 1 or 2, but then you do an echo, and it's totally normal.
Because the blood is just too thin, too watery.
Precisely. It's not viscous enough to flow smoothly,
Yeah.
so it tumbles and creates that sound. Other causes: high heart rate, high cardiac output states like hyperthyroidism, or even just fever or strenuous exercise.
Gotcha. So these are murmurs that fundamentally come and go with the flow. You treat the anemia, the fever breaks, the hyperthyroidism is managed.
And the murmur vanishes
Yeah.
because the underlying condition driving the turbulent flow is gone.
Okay, crucial point.
Yeah.
But how do we know not to panic when we hear one? What are the key features that scream benign?
Right. You need those differentiating clues immediately. First thing is loudness, the grade. Benign murmurs, always soft. Grade 1, maybe grade 2, max.
Okay, soft. What else?
They're short. They don't last the whole cycle. Usually mid-systolic, stopping before the second heart sound. And critically, you can't feel them. No palpable thrill.
A vibration on the chest wall.
Exactly. And the second heart sound, S2, sounds normal, sharp, crisp. If you hear something that's grade 3 or louder, you have to assume it's pathological until proven otherwise.
Okay, makes sense. And just quickly, the sources mentioned Still's murmur in kids. Any specific quality there?
Yes, Still's murmur, often described as having this unique, almost vibratory or musical quality.
Very cool.
Yeah, it's a weird description, but hearing that word itself is a big clue. You're likely dealing with an innocent murmur in a healthy kid or adolescent heart, not a structural defect. All right, so now we pivot. We're moving into the territory of structural problems, the grade 3 and louder murmurs. Something's actually broken or blocked or leaky.
Right. And this leads to chronic problems like volume overload or pressure overload on the heart chambers.
Exactly. And this is where nailing the timing is everything.
Okay, so for everyone listening, quick reminder, systolic murmurs happen during contraction when the ventricles are squeezing blood out. The mnemonic is Mr. Passus.
Ventral regurgitation, pulmonic stenosis, aortic stenosis, yeah.
And then diastolic murmurs. That's when the ventricles are relaxing and filling. That's ARMS.
Aortic regurgitation, mitral stenosis. Perfect. And the core issue is always either stenosis, the valve is too tight, can't open properly, causing a pressure problem.
Or regurgitation, the valve is leaky, can't close properly, causing a volume problem.
That's the fundamental split, pressure versus volume.
Let's tackle aortic stenosis, AS, first. Classic pressure problem. The valve letting blood out of the left ventricle is stiff, obstructed.
Right. And you see this mainly in two groups, like the sources said. Older adults, usually from calcium buildup, just wear and tear.
Makes sense.
But also, importantly, in younger folks, sometimes under 50, who have a congenital bicuspid aortic valve, born with 2 leaflets instead of 3.
Okay, so the LV has to push incredibly hard to get blood through that narrowed opening. What does that do to the heart muscle?
It leads to concentric left ventricular hypertrophy, or LVH. The muscle wall thickens inwards.
Bulks up to generate more force.
Exactly. More force, but the actual chamber inside gets smaller. And the sound, the murmur, really reflects that intense effort. It's harsh, often described as crescendo decrescendo or diamond-shaped.
Starts quiet, gets loud, then fades away during systole.
Systolic ejection murmur, best heard up at the right upper sternal border.
And it famously radiates, right? Up into the neck, the carotids.
Yes, that radiation is a key clue. But here's a bit of a paradox. If the heart's pushing so hard, why does the carotid pulse, the pulse in the neck, feel weak?
Yeah. The classic sign, pulsus parvus et tardus.
Small and late. It tells you everything. The pulse feels weak, parvus, because the actual amount of blood getting through that tight valve with each beat is reduced.
Okay.
And it feels slow rising, tardus, because it takes time for the pressure to build up enough to force the valve open and eject the blood. It's delayed.
Wow, okay, that clicks. The pulse directly reflects the obstruction. And what about those late, really serious symptoms, the SAD triad? Syncope, angina, dyspnea.
Yeah, those are ominous signs. Syncope is fainting, often with exertion. Dyspnea is shortness of breath.
And angina, the chest pain. What's causing that? Is it blocked coronary arteries?
That's the fascinating part. Often the coronary arteries themselves are totally clear. The angina happens because that massively thickened LV muscle, the hypertrophy,
Yeah.
its oxygen demand is just enormous. It outstrips the oxygen supply the coronaries can deliver, especially when the heart's working hard.
Yeah.
The muscle is essentially starving itself of oxygen.
It's a supply-demand mismatch caused by the hypertrophy itself. Wild.
Okay, let's flip the coin now to aortic regurgitation, AR. This is the complete opposite. It's a volume problem. The aortic valve is incompetent. It doesn't seal.
So blood leaks backwards. From the aorta back into the left ventricle.
Exactly. During diastole, when the LV is supposed to be relaxing and filling just from the atrium, it's also getting this backflow from the aorta.
Double filling. So now the LV has to handle its normal incoming volume plus all that regurgitated volume.
Right, which leads to volume overload. And the heart adapts differently here. Instead of thickening inwards, it undergoes eccentric hypertrophy.
Eccentric meaning?
It stretches out, dilates, the chamber gets bigger, more like an overstretched balloon, to accommodate all that extra volume.
Okay. And the sound?
It's different too. It's typically a blowing, high-pitched murmur, and it happens in early diastole right after the second heart sound, S2. It usually decrescendos, fades away.
Where do you hear it best?
Usually along the left sternal border. Sometimes the right lower sternal border if the cause is dilation of the aortic root itself.
Gotcha. But with AR, the physical signs are almost more dramatic than the murmur itself, aren't they? You mentioned the dancing pulses earlier.
Oh, absolutely. A physical exam in severe AR is unforgettable. It's all driven by that massive volume reflux.
So explain that wide pulse pressure. Why is the systolic pressure so high and the diastolic so low?
Okay, think about it. During systole, the LV ejects a huge stroke volume, its normal output, plus all that blood that leaked back in. So boom, systolic pressure shoots way up.
High systolic.
Okay, but then during diastole, as soon as the LV stops contracting, blood immediately starts leaking back out of the aorta into the LV because the valve is incompetent. So the pressure in the aorta plummets rapidly.
So low diastolic creates that huge difference.
Precisely. Wide pulse pressure. It's like toning a fire hose on full blast, high systolic, and then immediately having a massive leak spring in the hose. Low diastolic.
That makes sense. And that huge pressure difference, that massive volume surge, that's what causes the bounding pulses, the things like the water hammer pulse.
Yep, the Corrigan pulse or water hammer pulse. You can feel it very prominently, sometimes even see it in the neck arteries. And in severe cases, you get those really bizarre signs.
Like the head bobbing, de Musset sign.
Yeah, the Musset sign. The sheer force of the ejected blood volume is so extreme, it actually causes the patient's head to bob slightly with each heartbeat. It's a visible sign of that hyperdynamic, volume-overloaded circulation.
Incredible, just visually seeing the impact of the leaky valve. Okay, so we've covered valves wearing out or being congenitally wrong, but, you know, the sources also highlighted how sometimes the heart valves are just collateral damage, part of a bigger body-wide disease.
This is such a critical area because often the other signs, the non-cardiac signs, are what really clinches the diagnosis.
Right.
We move from just mechanics to systemic pathology.
Right. Where should we start? Maybe infections?
Infections are a big one. Let's talk infective endocarditis, i.e. this is a septic attack, essentially. Bacteria get onto the valves, usually valves that are already a bit damaged.
And they form these clumps, vegetation.
Exactly. Friable clumps of bacteria, platelets, fibrin, nasty stuff. And these vegetations do two bad things.
Hmm.
They can destroy the valve itself, causing acute regurgitation,
Hmm.
or pieces can break off and travel through the bloodstream as septic emboli, causing problems elsewhere.
Gotcha. And the sources mention specific bacteria liking specific valves.
Yeah, there are classic pairings. Staphylococcus aureus, that's a really aggressive bug, causes acute, rapid destruction. And it notoriously loves the tricuspid valve, especially in IV drug users,
Why the tricuspid?
because the contaminated injection goes straight into the venous system, hits the right side of the heart first. So the tricuspid valve is the first one it sees.
Makes sense. What about other bugs?
Then you have things like Streptococcus viridans. This group of bacteria usually causes a more smoldering subacute infection, often linked to, say, dental procedures weeks or months earlier.
Yeah.
Bacteria get into the bloodstream from the gums and seed a previously damaged valve, often mitral or aortic.
Okay. And there was one linked to colon cancer.
Ah, yes. Streptococcus bovis, or now often called Streptococcus galolyticus. If you find endocarditis caused by that specific bug, you absolutely must screen the patient for colon cancer. There's a strong association.
Wow. Okay. And for IE in general, there's that great mnemonic for the signs and symptoms from Jane.
Fantastic mnemonic.
Yeah.
Breaks it down perfectly. F is for fever, R for Roth spots.
These are retinal hemorrhages, right?
Yes. O for Osler nodes. Those are painful bumps on the fingers and toes. M is for murmur, crucially, often a new murmur or a changing one.
Okay. Jane.
J is Janeway lesions, painless spots on the palms and soles. A is anemia. N is nailbed hemorrhages or splinter hemorrhages. And E is for emboli, evidence of those little infected bits traveling elsewhere.
So some are from infection, some from the body fighting it, some from emboli.
Exactly. Janeway lesions and splinter hemorrhages are embolic. Osler nodes and Roth spots are more immune complex related. Fever is infection. And the new murmur tells you the valve is being damaged. Put it all together, especially with positive blood cultures. That's IE.
Okay, moving beyond infections, what about autoimmune conditions? Lupus, SLE.
Right. Systemic lupus erythematosus can cause something called Liebman-Sachs endocarditis or LSE.
Liebman-Sachs. Sounds different.
It is. These are sterile vegetations, no bacteria involved. It's caused by immune complexes depositing on the valves.
So inflammation, not infection. How can you tell it apart from IE?
Couple of key things. Pathologically, these LSE vegetations are classically found on both sides of the valve leaflets, the top and the bottom. Typical IE vegetations are usually just on the surface facing the blood flow.
Okay, location is key.
And clinically, the patient will have other signs of lupus rash, joint pain, positive ANA, anti-dsDNA antibodies, but crucially, their blood cultures will be negative. Sterile vegetations.
Got it. Sterile versus septic. What about carcinoid syndrome? That seemed really unique.
Oh, carcinoid is fascinating. You have a tumor, often in the gut or lungs, that's pumping out huge amounts of serotonin and other vasoactive substances.
And this affects the heart. How?
These substances, especially serotonin metabolites, cause fibrosis scarring of the heart's inner lining, the endocardium. But here's the twist. Most serotonin is metabolized and broken down in the lungs.
Okay. So
So the damage primarily occurs before the blood gets filtered by the lungs. This means carcinoid heart disease predominantly affects the right-sided valves, the tricuspid and pulmonic valves.
because they see the serotonin before the lungs clear it.
Exactly. So you look for signs of tricuspid regurgitation, TR, or pulmonic regurgitation, stenosis, PRPS. Combine that with the systemic symptoms of carcinoid flushing, diarrhea, wheezing, and right-sided murmurs that get louder when the patient breathes in. That's the picture.
Wow, the location of the damage tells the whole story. Okay, finally, genetics. Marfan syndrome.
Our fan.
Yeah. Defect in the fibrillin-1 gene affects connective tissue everywhere. In the heart, this leads to weakness, what's called myxomatous degeneration.
And which valves are most affected?
Classically, the mitral valve, leading to mitral valve prolapse, MVP. But also, very importantly, the aorta itself can weaken and dilate at the root.
Aortic root dilation, which can then lead to
Aortic regurgitation, AR, because the dilated root pulls the valve leaflets apart so they can't close properly. So you see a tall patient, maybe long fingers, lens problems in the eye, and they have MVP and/or AR. Think Marfan.
Got it. And one more genetic link, Turner syndrome?
Yes, Turner syndrome, 45XO. Strong association with two specific cardiovascular issues, a bicuspid aortic valve, which we said can lead to aortic stenosis later.
Right. And also coarctation of the aorta, a narrowing of the aorta, usually just after the arteries to the arms branch off.
Coarctation. What are the clues for that?
Classic signs are blood pressure differences. High blood pressure in the arms, but low pressure and weak pulses in the legs because the narrowing restricts flow downwards.
Makes sense.
You might hear a murmur over the back between the shoulder blades, and on chest x-ray, sometimes you see rib notching erosion on the underside of the ribs from collateral arteries enlarging to bypass the blockage.
Hypertension in arms, low in legs, rib notching. Points strongly to coarctation, often linked with Turner's.
Exactly. Systemic clues are vital.
Okay, this is brilliant. We've gone from basic sounds to complex syndromes. Now let's wrap up with maybe the most powerful tool for diagnosis right at the bedside: maneuvers. Physically changing things to see how the murmur responds.
Absolutely. These are quick, easy, and can instantly help you differentiate between murmurs that might sound similar otherwise. It's all about manipulating preload and afterload.
Preload being the volume coming back to the heart, afterload being the resistance the heart pumps against.
Correct. Let's start simple. Breathing, respiration, specifically inspiration.
Okay, breathing in, what happens?
Remember Carvalho's sign. When you take a deep breath in, the pressure in your chest drops. This negative pressure sucks more blood back from your body into the right side of the heart.
Increases venous return to the right heart, increases preload on the right side.
Precisely. So murmurs originating from the right side of the heart, tricuspid or pulmonic valves, will get louder with inspiration.
The mnemonic.
All right, inspire. Think about that tricuspid regurgitation murmur in the IV drug user we mentioned. Have them take a deep breath in. That murmur will get noticeably louder.
Okay, so right-sided murmurs increase with inspiration. What about left-sided?
Generally, left-sided murmurs like AS or mitral regurgitation tend to be louder during expiration. When you breathe out, you squeeze the lungs a bit, increases pressure around the left heart, makes those murmurs more prominent relative to the respiratory cycle.
Inspiration for right, expiration for left. Got it. Now, what about changing preload more dramatically, like with Valsalva?
The Valsalva maneuver, straining against a closed glottis, or even just standing up quickly from squatting. Both maneuvers do the same thing. They decrease venous return to the heart. They drop preload.
Less blood filling the heart.
Right. Now, for most murmurs, think ASMR, AR. Pulmonic stenosis, less blood flow means less turbulence. So these murmurs get softer or might even disappear during the strain phase of Valsalva or upon standing.
Less volume, less sound. Seems logical.
It is, except there are two crucial exceptions. Two murmurs that do the exact opposite.
The exceptions are always the key. Which ones?
Hypertrophic cardiomyopathy, HCM,
Right.
and mitral valve prolapse, MVP. These two murmurs actually get louder, or at least more prominent, when you decrease preload with Valsalva or standing.
Whoa. Why? That seems totally counterintuitive.
It does, but it makes sense if you think about the specific mechanics.
Yeah.
In HCM, you have this massively thickened septum bulging into the LV outflow tract, causing obstruction. When you decrease the volume inside the LV, less preload, the chamber walls actually get closer together, making that outflow obstruction worse. More obstruction means more turbulence.
The louder murmur. Okay, that makes sense for HCM. What about MVP?
Mitral valve prolapse is about a floppy mitral valve leaflet ballooning back into the left atrium during systole. Usually there's a mid-systolic click when it prolapses, sometimes followed by a late systolic murmur.
Right.
When you decrease the LV volume, less preload with standing Valsalva, the smaller chamber size means that floppy leaflet prolapses earlier in systole. So that mid-systolic click move closer to S1 happens earlier.
The click moves earlier.
And the murmur that follows it might become longer or louder because the prolapse is happening sooner and for longer. So decreased preload makes HCM murmur louder and makes the MVP click earlier and murmur potentially louder longer.
Whereas almost everything else gets softer.
Exactly. So if you have a systolic murmur and you have the patient Valsalva or stand up and it gets louder, you're basically down to HCM or MVP. That maneuver is diagnostic gold. Squatting, by the way, does the opposite, increases preload, so HCM and MVP murmurs get softer with squatting.
Fantastic. Simple maneuvers, huge diagnostic power. Hashtag tag outro. Wow, okay, this has been really clarifying. We started with this simple idea of flow murmurs, the benign sounds you don't need to worry about if you spot the clues.
Right. Grade 2 or less, short, no thrill, normal S2, often linked to a temporary state like anemia or pregnancy.
Then we dove into the big structural problems. Stenosis, the pressure issue, giving us that harsh AS murmur with the weak, delayed pulse.
Versus regurgitation, the volume issue, leading to AR with those crazy bounding pulses and wide pulse pressure, using Mesar Pass and RAMS to keep the timing straight.
And crucially, we saw how murmurs act like fingerprints for systemic diseases, linking IE to, from Jane, lupus to sterile vegetations, carcinoid to right-sided fibrosis, Marfan to MVP and AR.
And Turner's to bicuspid valves and coarctation. It shows how the heart doesn't exist in isolation. It reflects diseases happening everywhere else in the body.
It really drives home that point about murmurs being a language. What's the final thought you'd leave the listener with on this? What's the most maybe provocative idea from all this?
I think, for me, the most fascinating lesson is how incredibly specific and long-lasting these sonic signatures are. You know, a valve damaged by rheumatic fever from a strep throat decades ago still carries that specific sound of mitral stenosis. A tiny genetic flaw in fibrillin, in Marfan, leaves an audible mark of aortic regurgitation.
The sound persists.
It persists. These murmurs are like these amazing diagnostic echoes from the past, tracing the disease right back to its origin, whether it's an infection, an autoimmune attack, a genetic code, or just wear and tear. The heart truly records its history in the sounds it makes.
The heart as a historian, speaking through turbulence, brilliant.
Understanding the why behind the sound is really the key to unlocking the diagnosis.
Fantastic. Well, thank you again for sharing these sources with us. It led to a really productive dive. Maybe now go look up exactly how that preload change physically moves the mitral valve leaflet in MVP. See it in action. Thanks for joining us.